Thank you, Kimberly. Okay, welcome everyone to Department of Medicine Grand Rounds. I am pinch hitting for Wendy Armstrong today because she is away at Croy. And I'm very excited to be the person who gets to introduce Dr. Manpreet Malik. Many of you know him and love him as a beloved mentor, colleague, teacher, and friend. He is an internist and academic hospitalist with us here at Emory University in Atlanta. We were lucky to recruit him here from VCU, where he already had an established illustrious career. He's an associate professor of medicine at Emory, and clinically he works at Grady Memorial Hospital. He is also the beloved program director for the Transitional Year program at Emory, where he invests very deeply in every single one of those 28 residents who are spending their time with us for a year before they move on to advanced programs. But he's also a jack of many trades. So in addition to that, he is a national leader in point of care ultrasound. He has developed multiple bedside ultrasound guided procedure services at multiple institutions and is asked to consult in at other institutions regularly. He currently serves as a coach for the medicine procedure service at Grady, and he provides faculty mentorship to residents on the point of care ultrasound pathway at Emory, or the point of care ultrasound distinction pathway at Emory. He also teaches and directs bedside ultrasound and procedure workshops for numerous professional societies, including all the ones that we know and love, like ACP, SHM, and many others. We are so lucky for him to share his expertise with us today, where he will be talking to us about POCUS and a window into the future. Thank you, Manpreet.
Thank you, Dr. Law. Keeping it short and sweet over there. I appreciate it. Thank you so much. Since you mentioned the TYs, early shout out to my TYs who are here. Appreciate and love every one of them. There will be several shout outs to my hospitalist colleagues who are also here as well along the way. All right, let me share my screen, get started. I have a packed 100 slides. No, there's only 70. So let's get this party started. All right. Can you all see my appropriate slide set? Not yes. The presentation. Perfect. Thank you. All right. So when I started thinking about how to put this talk together, I was charged with covering the basics as well as thinking about where we're heading. I want to mention I have no conflicts of interest, and we will definitely cover a lot of the basics. We will cover and review diagnostic and procedural application of point of care ultrasound in medicine. We'll discuss some of our resident med student and faculty barriers to point of care ultrasound adoption, some of which you're very, very familiar with. We'll review some of the devices that are currently available, and we'll see where we're headed in the future. There's AI, or artificial intelligence, has a huge role to play in our future, and it's not just ChatGPT, although we'll talk about ChatGPT later as well. So buckle up, and this is what our roadmap looks like. We're going to talk about some common high yield applications. Your screen is going to look like your Instagram, just sliding up and up and up, except I'm doing all the sliding, and it's definitely not sliding into DMs. Then we'll look at some cases. I've tried to utilize cases from last week when I was scanning with my residents on procedure team. And we'll, like I said, talk about some of the barriers at Emory, not just nationally, and some of the devices we have and what we can expect. So my journey into point of care ultrasound. So a lot of you know that I'm a proud foreign medical graduate, and I got off the boat from India and started my residency in 2010 in a community hospital that is affiliated with UPMC. It's UPMC McKeesport. I have a picture of that hospital there. There was no hierarchy there. We directly interacted with our attendings in the ICUs on consultant services. There were no fellows. It was a small 12 to 13 residency program with people from all over the world. Some of them were FRCPs and MRCPs from England who definitely knew how to do their procedures and were great teachers. So what that did for a lot of us as residents who were really interested in procedures was we got to do all of our lines, all of our intubations, all of our chest tubes or pigtails. Not as many lumbar punctures as I would have liked, but definitely graduated with over 50 lines in 2013. In 2013, I moved to Virginia Commonwealth University. As Dr. Law said, we were very lucky to be able to get to an academic center after being at a smaller community hospital. That was the push for the move as well, is to be at a larger center and figure out how academic medicine works in the US. So very grateful to have been there for 6 years. But for the first couple of years, I really missed working with my hands. I missed my lines. I missed being able to do procedures and do more at the bedside. Any opportunity I would get that presented itself when a colleague was struggling with venous access or just needed a central line for a crashing patient, I was always available to jump in. And you know, it so happened that around 2015, we realized that there were some serious safety events in the hospital with residents not being adequately supervised, as well as not being, there were no standardized curricula for residents to do procedures, and there was no standardization at all in how procedures were being done. So in 2015, a few of my colleagues actually dragged our section chief over to a session led by Neelam Soni, whose book is pictured here, and Josh Lynch's, who had started procedure teams at their institutions at UT's in San Antonio, as well as University of Miami, Jackson Memorial Hospital, some of the OG procedure services in the country. And by 2016, we had put together a proposal and had a fully funded 2 FTE procedure service, rockin' and rollin' at VCU. All of the PGY2s rotated through the procedure service. We asked our hospital to fund some Josh Lynch's to come out and train us for 2 to 3 days. All very direct observation, and we went through some standardized teaching and training protocols that we're utilizing still there, and we've adapted at Grady as well since. So that gave me an ultrasound. The ultrasound I got is pictured over here. It was a Sonocyte Edge 2. It's a laptop style ultrasound. It's still there. It's still working, although it looks very beaten up. Sometimes my former colleagues send me pictures of that ultrasound and say, hey, look at our old buddy. They're still doing procedures, and a lot of them have definitely graduated to doing a lot of bedside ultrasound. So just having an ultrasound allowed me an opportunity to scan a patient every time I finished a paracentesis. The patient's feeling very grateful for getting the comfort from a paracentesis, and we're ready to do some heart ultrasound, some lung ultrasound, some IVC ultrasound. In 2017, I met Mikhail Akbashev while I was still at VCU. A lot of you guys know Mikhail. He's a GIM and a POCUS expert at Grady. He said, why don't you come down to Emory? We can do point of care ultrasound together. Around that time, I got opportunities to teach at multiple different courses. Same in 2018, got to teach here. Dan Gressler invited me, and Neelam Soni thought that it was a good idea to give me an opportunity as well. And since that time, it's just been nonstop, and have been able to get tons of opportunities to learn and teach with some amazing faculty mentors, and continue to do so. So that's my journey into point of care ultrasound. Let's stop talking about me and jump right into it. I can obviously not cover every scan in a 1-hour presentation. This would be a 2-day course at the minimum. So what I'll try to do is go through some of the basic scans very quickly, talk about a few cases. Please hold your questions till the end if possible. So the 3 probes that we typically use are linear array probes for superficial applications, soft tissue MSK, pleura, vascular applications, curved array probes for abdominal and pelvic imaging. They're lower frequency probes, provide not as clear an image as linear probes, but definitely able to look deeper into the body. Phased array probes are smaller footprint, and they're great for getting in between those ribs and getting great cardiac images. The phased array probe, if you don't have a curvilinear probe, is typically good enough for abdominal imaging as well. But when you're looking at kidneys and bladder, you need something that's a slightly wider sector to catch it all in one window. So a curvilinear is great for that. Sorry about that. So there are tons and tons of applications. We obviously cannot go through all of them. So what I decided to do was try to cover a few here and only certain aspects of a few, and we'll jump into procedures a little bit later. Here's the evidence for lung ultrasound. There is a similar slide for this with lung ultrasound compared to physical exam and multiple other ultrasound modalities compared to physical exam. The likelihood ratios on that are almost embarrassing. So we'll stick to the chest X-ray versus lung ultrasound. Ultrasound is so far superior in detecting pulmonary edema, pneumonias, effusions, pneumothoraces with absence of pleural sliding. It's a fantastic extension of your physical exam. A lot of times people will say, well, does this replace the stethoscope? I think that's all clickbait. I don't think anything replaces the stethoscope. I don't think you can hear wheezing on an ultrasound, but it really comes as close to having direct eyes into somebody's body as you possibly can. So it definitely increases diagnostic accuracy, and most societies have endorsed point-of-care ultrasound for undifferentiated dyspnea. Normal lung ultrasound, you want your probe with your probe marker in between the ribs with the probe marker pointing towards the patient's head. And this is what you see. You'll see soft tissue up top, pleural line, which is sliding, kind of has a sliding appearance of ants kind of crawling, or just a shimmering appearance that is normal. And you'll have what looks like artifact, basically like an echo chamber, well, where you say pleura, 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 pleura again, and it basically comes back. The beam hits the air, comes back, hits the air, comes back, and it's kind of like an echo and creates an artifact. This is normal. These are A lines. Let's look at where you scan. We typically recommend an 8-zone scanning structure with zones 1, 2, 3, and 4 on, and 5, 6, 7, or 8 on each side. Typically, how I mark when I'm doing this ultrasound is R1, R2, R3, and R4, and then L1, L2, L3, and L4, and that's how I will label my images. I'll have an example of that here in a second. This is an example of A lines on the right, B lines on the left. B lines typically indicate congestion or interstitial edema. Sometimes they can indicate pneumonias, or subpleural consolidations can give you B lines as well. Here's a picture of a classic lobar pneumonia with a small parapneumonic effusion. This is your diaphragm in the center of your screen with the liver right under it. The curved structure is the diaphragm. You can also see the white hyperechoic spine behind this. Typically, if you had air in this area, you would not see the spine, because air is the enemy of ultrasound. This is also a positive spine sign. Here's an example of what happened in 2020. When we all started seeing COVID, this is a patient I scanned in April or May of 2020. You can see these wide, almost flashlight-like B lines here. You can see them a little bit better on the right in the R3. And this is a Twitter handle for a physician who's in Spain. He scanned himself every single day in his COVID journey when he got COVID. And you can see those big flashlight-like B lines. They're still there. In fact, recently we had a patient which some of you would remember while we were on service recently. Our patient continued to be fatigued and had fever, and we couldn't figure out why, and we decided to scan them and found B lines. We're like, well, is there something viral going on? And COVID was negative, and obviously they had what was going on early this year is influenza. So viral pneumonias can give you a B line pattern. Similarly, because of interstitial patterns. Effusions, here's a basic effusion on the left, a purulent effusion on the right. You can see the echogenic material in the dark fluid over here with the collapsed lung. Here's a more complex effusion right in the center, which is loculated and septated. And this is definitely where I would call my pulmonology or CT surgery colleagues to see whether the lung is trapped or whether this patient needs a VAT surgery. Let's jump into the abdomen. So for the abdomen, the areas that you would scan are the right upper quadrant, the left upper quadrant, the pelvis, and you can also look at the aorta and the IVC and the subxiphoid areas. There's tons of protocols in the ER. There's the FAST exam, there's the extended FAST exam, and then there's hemodynamic protocols like rush exam for trauma. We'll not get into those, just becomes very long, but those are all available online for you to review very quickly. So applications for abdominal ultrasound are looking at free fluid. You can detect up to 100 cc's of free fluid, typically collects in the right upper quadrant in supine patients, and in patients that are not exactly supine or even tilted a little bit with their head up, it'll collect in the pelvis first. For left upper quadrant fluid in trauma patients, it'll collect in the infradiaphragmatic space and not necessarily in the splenorenal space. Abdominal ultrasound is great for looking at hydronephrosis for bladder. I find that bladder is a huge, huge utility for all of our post-op patients, all of our delirious elderly patients who somebody somehow hasn't had a chance to bladder scan, or patients with ascites, because bladder scanners can't distinguish between ascites and distended bladders. Aorta and IVC and gallbladders. Will not cover gallbladders for this talk. Here is a normal right upper quadrant ultrasound with the liver, the kidney, the hepatorenal space, and you can see the spine and the diaphragm in the corner. Here's a normal left upper quadrant ultrasound with the kidney, the spleen over here. Here's free fluid in the abdomen. You can see that the fluid collects in the hepatorenal space. See the kidney right here in a second. And on the left, the fluid collects, typically free fluid will collect in the infradiaphragmatic space. You can see the spleen here and the kidney right below it. Free fluid in the pelvis. Here is a normal bladder. And here is fluid outside the bladder. Remember, free fluid has is not contained within a circle, so it has no boundaries. It definitely has edges and curves, but it is not enclosed. So kidney and hydronephrosis. Here's a picture of a normal kidney on the left. Here's a picture of an obstructed urinary system with increasing urine collection, therefore hypoechoic areas in the center of the kidney. And as the kidney becomes more and more distended with fluid in the pelvis, fluid pushes back over to the cortex and creates more and more hypoechoic areas in the kidney, eventually with severe hydronephrosis looking like a bear claw. All right, let's take a break from all those images from scrolling and think about a case. So this is a 64-year-old patient I saw last year on procedure team who comes with history of shortness of breath, new oxygen requirement, subjective chills, test negative for COVID and test negative for influenza. So we really don't know what it is, but also get a CTA for PE. These are the days where we were really worried that everybody with COVID or everybody with a viral infection was coming in with a PE as well. So we're called because the creatinine has now gone up from 1.5 to 4. Patient has AKI and is somewhat obtunded, is oliguric, and they're either worried about contrast or just don't know what happened. And in my head, I'm not sure what's going on, because is contrast nephropathy even real? We've been told it's not real recently, and then we've been told it's real. So something doesn't add up. This patient's blood pressure has been fine. They don't have COVID. As I'm thinking these thoughts, I'm scanning their IJ, and I see this big, juicy IJ, and I really, really want to stick it. But I can't necessarily separate the medicine doctor out of the procedure doctor. And so I end up looking at this bladder. I told you that bladder is a great high yield application for me. And so look at this bladder. This is this patient's bladder. It's distended. It's got at least 800-900 cc's of fluid in it. This is the bladder in longitudinal. It's a massive bladder. Should not have happened before calling a proceduralist for an invasive procedure, but it's what happened. So I'm going, whoa. And we get a Foley in, this patient starts diuresing and feels better in 2 days and gets out of the hospital. So bladder is very, very high yield for point of care ultrasound applications. And there's ways to measure the bladder volume with a correction factor, which is pretty easy to do. We'll move to cardiac ultrasound. So cardiac ultrasound uses, you can look at LV, RV, systolic function, wall motion abnormalities, valvular function with color Doppler and other measurements. We'll keep this very basic and not jump into a lot of advanced cardiac ultrasound. IVC for CVP estimation. I try to tell everyone that IVC in isolation for volume estimation is not a good idea. Please use it with lung and cardiac ultrasound. Jason Williams, one of our POCUS experts at VA, does a formal diagnostic POCUS program and assesses volume status every day on that service. So the key areas that you want to scan are 1, the peristernal area, 2, the apical forechamber, and then 3, the subxiphoid and substernal area. Here's a peristernal long axis with your probe marker pointing almost towards the right shoulder. If you're going to remember body parts or anatomic landmarks, you're going to remember right shoulder, and left elbow, or just right shoulder and left shoulder is often enough to remember. Here is a normal plaques or a peristernal long axis view with all the structures that are labeled: left atrium, left ventricle, descending aorta, pericardium, the mitral valve. This is the anterior leaflet. This right here is the interventricular septum, the right ventricle, and pericardium over here. This is the aortic valve. There's a lot of literature supporting endpoint septal separation. I've linked with a QR code an article. This is an OG article from 1977 when the conversation started on endpoint septal separation on estimation of EF with this measure. Basically, if the anterior leaflet of the mitral valve is getting within 1 centimeter, which it is here on M mode, of the interventricular septum, you have good myocardial thickening and good endocardial excursion towards the center of the left ventricle, up to 30 to 40% of you, but a lot of us eyeball this. Chances are that your EF is normal or at least over 45%. We can get very technical about EF measurements, but I'm the first one to tell you that I'm not a cardiologist, and I use point of care ultrasound for point of care reasons in terms of what I might want to do next or who I might want to call next. Peristernal short axis. Again, this is a normal view at the papillary muscle level. Great view to look at wall motion abnormalities. And for RV overload states, acute PEs, this is the wall that goes into the LV and RV starts enlarging. And the classic D sign happens if you're expecting an acute PE. So this is where you would see all of that. Kind of think of this circle as almost biting your finger if you were to put your finger on top of it. And if it's not all moving together at the same time, or if one wall is not moving, there's probably a circulatory or a conduction abnormality that is causing that. All right, 4-chamber. This is the view everyone loves to see, but everyone struggles to get in point of care ultrasound. Here's the structures that are all labeled. Again, left atrium, left ventricle, mitral valve, tricuspid valve, right ventricle, right atrium, and your pericardium. This is your probe orientation, almost to the left elbow, but typically you'll have to rotate a little bit counterclockwise to get a good view. Turning patients over to the left for a good apical view always helps. It really helps in patients with COPD and tall and thin patients sometimes. All right, subcostal view, really great view for patients with who are getting CPR, patients again who have COPD. You can actually get 4-chamber and short axis and long axis views in the subcostal area. This is a normal subcostal 4-chamber view. Notice the RV thickness here is pretty normal. We have a case later where the RV thickness is not normal, and I'll show that to you guys in a little bit. We unfortunately had a patient who coded this weekend, and this view was helpful. While CPR was going in, every time we took a pulse check, we were able to see cardiac standstill and no motion, and therefore that was helpful during resuscitation. IVC. Everybody loves the IVC. Again, my 2 cents, if you take nothing away, PLAX is a great view, and IVC, don't use it in isolation. Please add lung ultrasound and cardiac ultrasound to IVC for your volume estimations. And IVC ultrasound, just don't rely on measurement. Please think about collapsibility as well. Here is a normal IVC view with the IVC going into the right atrium. This is what you want to see with the hepatic vein over here. Typically, you would measure the IVC right distal to the hepatic vein or within 3 centimeters of its entrance to the right atrium. Remember to not confuse the IVC with the aorta. IVC is always a sliver in the liver. Aorta always has the vertebral bodies behind it, and is, if you're looking at the patient, it's towards the patient's left. The IVC is at the right costal margin for the patient. Please don't give people diuretics after looking at the aorta. Common mistake that happens. This is a little bit more data on the IVC. I've included a lot of QR codes, knowing that I won't be able to get through every single paper and every single teaching or talking point on some of this. So please use IVC for CVP measurements and utilize this to measure where you are in terms of volume status with the collapsibility, or collapsibility index, as some papers will call it. Oh, I want to mention this QR code if you're really into point of care ultrasound and are into color Doppler or continuous wave Doppler and pulse wave Doppler. Here is a fantastic 15-minute video from Dr. Koratla at Medical College of Wisconsin, who discusses hepatic vein and renal vein Doppler in addition to IVC for volume status estimation. He's a nephrologist and does great work. Abdominal aorta, quickly, I just have 2 slides on this. You can measure the abdominal, great primary care application for people who smoke, are above 65 and need at least 1 abdominal aorta scan to see if they are going to blow that aorta or have a dissection or it's expanding in size. You can measure the aorta. You want to try and measure the aorta in both dimensions and try to catch outer wall to outer wall. Anything over 3 centimeters should start suggesting you need to monitor it more closely. Make sure you don't, when you're trying to measure it in longitudinal section, try not to catch the side and avoid cylinder effect. This applies to the IVC as well. DVT ultrasound, fantastic application of point of care ultrasound. You're going to use a linear array probe for this application. There is tons of fantastic evidence for point of care ultrasound done by hospitalists, done by ED physicians, done by anesthesiologists, done by critical care. There's great data. All of them have a sensitivity of and specificity of over 90% in detection or ruling out DVT. With point of care ultrasound. I have linked a an awesome review paper that talks about training, talks about all of the other articles that are out there. This by various and a bunch of New Jersey colleagues who wrote this article. And then, of course, hospitalists did not want to be left behind and wanted to come up with a creative name and wanted to show that we can beat our cardiology colleagues in coming up with cool names. So there's a Hocus Pocus study by Fisher, who's at Georgetown, on point of care ultrasound done by hospitalists. They actually had almost 100% sensitivity with minimal training when done by hospitalists. And they were able to show that hospitalists were able to get the point of care ultrasound done in 3 hours versus waiting 11 hours for a formal study, and were able to get treatment started early in positive cases. Here's an example of a left lower extremity DVT. You can see the clot in there. The key here is to collapse the vein so that your walls touch each other or kiss each other, so that you can rule out a clot. Non-compressibility is more of a friend than actually visualizing the clot inside the vein, which you can see here. You may have the beginnings of a clot here, but it's the non-compressibility of the vein all the way where you really get the benefit of this. Some of the early clots are not yet echogenic, so you'll miss it if you are just looking for something that's echogenic in a blood vessel. Procedural ultrasound, this is some of my favorite stuff. This is what I love doing. This is what I've been doing for many years, and I love teaching as well. All right, so how do I use ultrasound to augment the safety of my procedures? What do all of us in our procedure team do as a standardized practice as well? Love to talk about this. All right, this is a right IJ of a patient we scanned earlier. We emphasize to everyone that you want to scan the entire length of that blood vessel before you even consider sticking a needle in. You can see in this IJ, when you compress cranially, there's no clot, but as you go down, there is a clot. You would not use this right IJ for a central line. You want your blood vessel to look like this. This is a femoral vein scanned by Dr. Jeannie Ho, who was on procedure team with me last week, and did this central line like actually a dialysis line, like a complete boss. So you use ultrasound to confirm guide wires. You can see this shiny guide wire that's in the vein. And you want to do that before you dilate your way to putting in the central line. There's another picture of the guide wire in the right IJ. So those are at least the very basic things that you would do with ultrasound for a central line. Here's what additional stuff you can do, because there's obviously more. You can actually inject agitated saline into your line once it's placed to confirm placement, so you don't really have to wait for an X-ray. If it's on the venous side of the circuit, you've just confirmed that your line is in the correct place. So this is injecting bubbles into the central line or agitated saline, and you can see these bubbles come within 2 seconds of your injection over here. Here's another picture. This is actually a really neat subcostal view of after a line placement, where you can see the bubbles come in through the SVC into the right atrium and go through the tricuspid valve, hang out in the right ventricle for a little bit, and then go into the pulmonary artery over here. Great picture, stolen from one of my friends in New York. All right. Paracentesis. Paracentesis safety. You are obviously going to use it to isolate a pocket and mark where you are going to stick the needle. But wait, please use color Doppler to identify the absence of blood vessels in the area that you're going to stick. You do not need to scan for inferior epigastrics or necessarily look for inferior epigastrics, which is what we're always worried about. but at the very least scan in the area with an appropriately reduced color scale or a flow scale to make sure that there are no blood vessels in that area. Here is an example of epigastrics that you don't want to hit. And there is enough evidence right now, and SHM has a position paper on ultrasound use in paracentesis that tells you to do this for every paracentesis. We don't do enough fluorocentesis on our Grady procedure team because we have 2 great pulmonary services here, but for every thoracentesis, you want to do the same thing before you stick in the intercostal space, because there can always be collaterals and aberrant blood vessels. Ultrasound used for lumbar punctures. Here's what we use for lumbar punctures. We use a linear probe for patients that are not very large to identify spinous processes, which you can see here in transverse section. And I tend to mark my L3, L4, and L5 and my midline, and then mark a spot in the interspinous space. Here you can see it on the right in a longitudinal section, and then identify where my needle is going to go. There is a way to do a paramedian sagittal oblique view, and you can determine how long your needle needs to be or how much needle will go in before you hit, because you can visualize ligamentum flavum and make sure that your needle is long enough in certain cases. Arthrocentesis. This clip is from Dr. Ho doing an arthrocentesis on Saturday this past week. Here's other examples. This point of care ultrasound completely changed my practice. I was taught landmark method, maybe not so well. And I would frequently go medial or lateral to the patella. And I'm not sure if I've stuck lateral or medial menisci all this time that I've done procedures. But as I've gotten more comfortable and drank the ultrasound Kool-Aid, all of my arthrocentesis are now suprapatellar, under direct visualization. As you can see, you can practically watch your needle and enter into the fluid and aspirate or inject under direct visualization. All right, let's do at least one more case before we jump into curriculum and med student and resident stuff. Here's another case we scanned this past week, 54-year-old with shortness of breath, old echo with reduced EF of 35%, has history of heart failure and COPD, not taking any meds, and we're asked to scan volume status because primary is not seeing JVD, not seeing volume, but patient came in short of breath and is worried that they may still have heart failure and may still need diuretics. So we'll figure out if this patient needs diuretics or not. Here's a quick scan. These are not the greatest images, but they're good enough. So there's a quick scan of parasternal long axis. You can see the anterior leaflet of the mitral valve is moving, but really doesn't come too close to, we're eyeballing this, doesn't come too close to the interventricular septum. Not the greatest view to look at your apex, that's normal. Not a great view to evaluate RV function either, but you can see that the RV is not huge, right? So already starting to think what the volume status might be here. Here's a short axis view at the almost at the papillary muscle. Some of the mitral valve is showing. The RV is not huge over here either, but something you can see is wall motion. The septal wall isn't moving at the same time as the rest of this ventricle. So there's some problem, right? And all of it's not moving inward, doesn't contract as the way it should be. We already knew that this patient has somewhat of a reduced EF. As a hospitalist, I don't need to go crazy doing measurements. I know there's a problem and there's some wall motion abnormality. I have to figure out, and I might need help from my cardiology colleagues, but we still haven't answered the volume question. Here you can see the same thing here in a 4-chamber, right? You don't necessarily have great motion of all of the walls inward, but you don't necessarily have a really large RV or an RA. So your volume status might be fine here. Subcostal, same thing, not a great image, but basically tells you what your 4-chamber did a minute ago. Let's look at that IVC. We all love that IVC, don't we? Look at that, literally a sliver in the liver, totally collapsible without even asking the patient to sniff. This is inspiratory collapse of that IVC emptying into that right atrium. This patient does not need diuretics, regardless of what their EF is and their shortness of breath might be. So also always said that we need to use lung ultrasound. Here's A lines, right? No B lines here, and definitely does not need diuretics. So we can move forward with that. So we were able to help the primary with volume status on that one. Here's another case. This is a really unfortunate case. This doesn't give you a lot of information other than what you already knew, that this patient is young, has end-stage renal disease, is undocumented, and does not get enough dialysis likely. But we see this all the time, sadly, at Grady, and it really kind of sucks for some of these patients who are not necessarily getting as much dialysis as they can, but or as they need. But here's a picture of their right lower quadrant, because we're called for a paracentesis. Their last paracentesis was almost 6 months ago. You can see this fluid is a little bit more echogenic as well. This fluid has been in there for a very long time. Therefore, it's more dense than something that collected fairly quickly. And we checked with the ultrasound to make sure there's no blood vessels. Here is their IVC. The fluid is pushing on it so much, it's really difficult to visualize, but you can see that the hepatic vein is dilated. The RA looks huge as well. Here's a subcostal. Look at that RA. It's huge. Remember we talked about the RV thickness? That RV thickness is also huge for this patient. This patient's had chronic right-sided overload for a very long time. This didn't develop overnight. Look at that LV as well. That LV wall is so thick. So we can clearly say that there are problems here for this patient. The left atrium is big, right atrium is big. There is a pericardial effusion if you look carefully as well. Not hemodynamically significant, but there is a pericardial effusion. Same thing with this, kind of gives you the same picture with things not moving as well as they should. LV is not doing its job. It's thick. LA is thick, and RV is also a little bit bigger than what it needs to be. We'll skip this for simplicity's sake, but you can throw color Doppler to figure out pulmonary regurgitation and look at the jets there and do some calculations if you have color continuous Doppler, which I didn't have that day. All right, so for that patient, we were able to talk to our primary team and advocate for him to get more dialysis than he was getting. Sometimes our Grady team has been able to make exceptions, and patients have been able to get more dialysis more times a week than they have been, just so that they can be a little bit more symptom-free. All right, switching gears from a lot of clinical stuff over to logistics and credentialing. So Grady is a little bit ahead of the curve and has a credentialing pathway that, again, Dr. Akbashev and I put together a few months ago, and have a pathway for all of us to get credentialed in the Department of Medicine for point-of-care ultrasound. It closely mimics SHM's certification of completion pathway. I will say that again, it's a certificate of completion pathway, not a certification pathway, and it does not mean that it's credentialing. Although Grady has been very liberal in thinking about credentialing in a holistic way, where if you have done this pathway and can show that you have completed it, credentialing becomes a little bit easier for you. But credentialing is up to each institution, each hospital, and their med exec. We are at a point where this needs to go to med exec and has Dr. Lennox's blessings. But in order to get more people credentialed, we need faculty support and time to be able to review images and move people along this pathway. I want to highlight and shout out a bunch of point-of-care ultrasound people at Emory and Grady. This may not be all of them. I apologize in advance for folks that I might miss. Mikhail Akbashev, I've mentioned him multiple times. Lorenzo Di Francesco, who runs our POCUS distinction pathway. Jason, who runs the point of care ultrasound, and is the director of point of care ultrasound at VA. Sneha, who's the assistant director there. And all of these other people, Dr. Daniels, Dr. Greer, Dr. Connor, Dr. Schuler, Fiza, and Suarez, and Harris are pulmonary critical care, nephrocritical care, and ID critical care, and teach, educate, do bedside point of care ultrasound, and train multiple people each year. Mikhail, if you are on the call, you're welcome to tell us a little bit more about what you're doing at Grady in maybe 30 seconds to a minute.
Thank you. Thank you. I'll add Randy Hunt on here with the pulmonary critical care.
Yes, I'm sorry. Yeah, I knew I would forget someone. I've definitely worked with Randy a lot.
Definitely a lot more people than you could fit on a list. But at Grady, I'm very proud with the residency and the residency support with the work we've done with the residents. Every resident for the last 7 years before they graduate will do a 2-hour seminar. It's a 2-on-1 with faculty as well as a curriculum where they receive some exposure to point of care ultrasound, but this really isn't the kind of thing that you can learn from a 2-hour seminar. It's a clinical skill that needs to grow just like we did with our reflexes and our stethoscopes and our EKG and X-ray interpretation. And so I'm excited to help support Dr. Di Francesco's distinction, where we'll have 8 residents having graduated with a distinction at the end of this year, who've done academic projects, who've built portfolios of images, and have gone on to either fellowships or practice where they've incorporated ultrasound. And we really haven't captured all the residents who want to do it. You know, we have over a dozen apply each year, and we only have a handful of faculty and a handful of devices to help support this. And we have residents who are buying their own devices and trying to learn themselves on top of it. So I'm very proud of the residency program. But the thought that I'd leave you with is, imagine a world where attendings didn't know how to use reflex hammers. You have residents going around and saying, I think this is clonus, and I think this is hyperreflexia. So we definitely need more mentorship and support for these residents who are learning a new clinical skill that can be very helpful.
Awesome. Thank you, Mikhail. I appreciate it. I'm not sure if Jason is here, and if Jason can unmute and tell us quickly what he's doing at the VA, and if Dr. Daniels or any of our pulm care crit faculty are here, how they're contributing as well. Jason?
Hey there. I don't want to take too much time from your wonderful presentation, but at the VA, we're very lucky to have 3 core faculty in point of care ultrasound that runs our point of care ultrasound and procedure service. And it's going to be 4 soon. Caroline Coleman, our 3rd-year medicine resident at Emory, is going to be joining our group. So we're really excited to have her soon. I looked back in anticipation of this presentation. During the last academic year, we've trained 37 residents, 4 pulm critical care fellows, and run 14 point of care ultrasound and procedure workshops at the VA in the last year. So we've been trying to stay busy and try to help out our learners as much as we can, and most importantly, help our veterans over at the VA.
Awesome. Thank you so much, Jason. At the end of the day, it's about our patients and then about our learners as well. We're definitely making an impact with point of care ultrasound. I'm not sure if Dr. Daniels is here, but please unmute and interrupt me if you're here. All right, great. I want to also shout out to our Grady procedure team, who are just doing incredible work in moving the needle forward in our throughput. And Mikhail, you're part of that as well. So thank you to Srini, Carmen, Lakshmi, Mike, Toby, and Chris. I use first names because I know all of you. So thank you. I appreciate you. We have a bunch of folks graduating, as Mikhail said. And we have a lot of hospitalists at different sites. We have Malia Willis at Midtown, and Bashir Gear and Katino, who's one of our OG procedure docs and is the director of the Midtown Hospital Medicine site. And then we have Patricia Chung, who's just joined us at Grady. Caroline Coleman, as Jason said, is joining the VA, and Seema Mustafa and Jeannie Ho are eventually going to be at Grady as well. We have people coming through the ranks, and we're really, really excited about where we're going. So thank you. So at the end of the day, it's teams, and very excited to see where we end up in 2 to 3 years. All right, what is the path forward, right? We're starting to get to a point where we're getting some faculty who are interested, who feel supported and are doing a lot of good work, right? Every major organization that we work with has either a position statement. If you're at SGIM and have some sway there, please ask them to work on this as well, and we will push for it as well. But the SGIM needs to put out a statement, but every professional organization has a position statement on this at this point and encourages formal curricula, formal use. This is something that is here. We are behind the ER and critical care by 10 to 15 years. Maybe because the devices were too big and we couldn't lug them around on our backs from floor to floor. Maybe because of inertia, maybe because we're just more averse to change because we really want to teach them what we know and not necessarily pick up something new that feels a little frightening. But it's here. We need to do this, right? So what are the characters of what's happening with residency programs? There was a 2020 survey done by Charlie Lopresti, who's in Cleveland, and Jason's worked with Charlie for a few years. They created a survey and sent it out to 429 program directors with a 60% response rate, which is great for a survey, especially for that kind of a survey that is long. And 95% programs said they had some sort of exposure, and 60% of them said they had a formal curricula. Now, formal curricula doesn't mean that they're all coming out as experts, right? And we have formal curricula, but not necessarily all of our residents are proficient or competent. And that may not even be the goal, but there is a movement towards having formal curricula. Out of that survey, almost 77% said the biggest barrier was having faculty who are experts or faculty champions. The second biggest one was having faculty who had the support to do this, and they were not just doing it out of the goodness of their heart. Pun intended, because cardiac POCUS, right? And then financial support for devices, right? If you're looking at carts, these are $40,000 to $70,000 devices. They're not cheap, but again, it's here. We need to do something about it. POCUS in med schools. In 2014, there were at least 60 med schools already adopting point-of-care ultrasound curricula. At my previous institution, VCU, we had an M1 through M2 longitudinal curriculum. Many schools have M1 through M4 longitudinal curricula. Emory has MS3 and MS4 ICU, ER, and M3 workshops that Randy and Mikhail run. Dr. Daniels and a few others from critical care also lead some of these workshops. There's actually an impact workshop in 2 days that some of us are going to help facilitate after hours, again, out of the goodness of our heart and because we want to do it. But again, highlighting some of the lack of formal structure and support, but evolving support. As Mikhail said, we've done really well at the residency level and have had fantastic support from Dr. Law and now Dr. Himrajani as well. There isn't a longitudinal curriculum, and I was talking with Dr. Daniels about this yesterday, that maybe we need to move forward. That's an opportunity for us to work on. There's definitely not enough devices. There's really not even enough devices in our sim lab. We need an investment there. And I feel like that's another area of improvement. So opportunities, I think M1, M2 curricula, formal procedure and ultrasound electives in M4 years. We had sub-Is rotating with us at VCU. Early exposure and formal training for those interested in critical care and cardiology, even hospital medicine. We have faculty. We could potentially think of POCUS distinction expansion, whether that's residency or starting people early in med school if they really know what they want to do when they grow up. There are a few point-of-care ultrasound fellowships out there that are hospital medicine run. Cornell and OHSU I think Penn has one as well, and there's one in South Carolina. So there are a few of those out there that are pretty awesome. And then CME courses in Atlanta. How many courses do you know of that are in Atlanta? Almost none. We run a small introductory course for Southern Hospital Medicine. Having a large academic institution like Emory and having no big courses in Atlanta, which connects 80% of North America, right? We talk about our airport all the time in our recruitment pitch, but we don't have big courses here. So great opportunities. And then, of course, funding for money, right? Funding for more devices. I won't spend a lot of time on these carts, cart-based devices, 40 to 70,000, all of them. I have a slight preference for GE because of their cardiac suite, but all of them basically do the same thing. Grady is a big Mindray site, and the image quality is fantastic. I think the AI is a little bit ahead for GE at this time, but everyone is incorporating AI into their devices. The vScan Air, there's a comparison paper from Dr. Soni of 4 handhelds, the top 4 on this list. And the vScan Air basically won the crown on that. It's about 5,000. We also use that device for our global health program, and we bought 2 of these and sent them to our colleagues in Ethiopia at Blackline Hospital. Thank you, Dr. Kemker, Dr. Riboyido, and Kalisha Ajala for actually getting this journey started for us. We created a really awesome program for them to learn POCUS virtually last year. But there are a lot of handhelds. I feel like if you really truly want a handheld, vScan Air is the way to go. Probably the worst kept secret in the industry is that there is a phased array and a linear array probe that is coming to market soon for the vScan Air. So if you're thinking of buying one, wait a couple months. EchoNews Cosmos is what we went with recently. For our Emory residency program, we bought 3 of these last year. It's a fantastic device, does color, continuous Doppler, pulse wave Doppler, and can measure all of those cardiac measurements. AI is really here. It does all of these automatically without waiting for me to actually pull my calipers and measure dimensions of the left ventricular outflow tract and do it wrong 4 times. It does it for me, and it's more repeatable, it's more consistent. And there is already evidence in papers that there is better measurement consistency with AI than what me or an experienced tech can do. So AI is here. These are 2 that we met recently at a point of care ultrasound course. The US2 AI folks do a full echo, generate a full report with me just providing the images, does everything for me, as long as I know how to acquire those images. But wait, it can even guide my hand as I'm acquiring those images to get me a better image than I can get myself sometimes. Same thing with ultrasight, it's more teaching focused, and it links with the Lumify, the US2 AI links with the Cosmos device. And basically they don't miss anything. I might miss something, it doesn't miss any of those 38 FDA approved cardiac measurements when I'm trying to get VTI and hemodynamic parameters. This is my last slide. I know we're at time. This is the future of image archiving. This is borrowed from one of my colleagues in California who is helping their health system put together an image archiving system that works for the whole health system. So basically what will happen in future state is we will move from servers that are housed locally at institutions to cloud-based image archiving. If we haven't started thinking of that, and I'm not a radiology IT person, I don't think I get paid enough to do that. But at the end of the day, this is where all the data is being housed. Microsoft and Amazon are housing government data on their cloud-based systems. This is coming to hospital medicine and to point of care ultrasound, to cardiology, to radiology. This is happening. The AI is going to help us determine a lot of this. It's already built in, the programs and the measurements and the abnormalities are already there. The software and the AI is there. It's just moving the needle over the next 10 years into where, what enterprise vendor neutral systems, vendor neutral archiving systems, which is the VNA over there, we're going to buy for Emory Health System or for Grady and so on and so forth. So that's a kind of a look into the future of where we're headed. So because we're ending with AI and all of this, I thought about asking ChatGPT how I should end this talk and got this message. So I think we're all at capacity and I've talked a lot. I didn't think I would be able to cover all of this, but we're here. And thank you for coming to my POCUS Grand Rounds. And here's the information on all of the courses that you can take through SHM. And there's some of my favorite courses are the Cornell course and Neil and Sony's course if you ever need more resources. This is what I feel like. I'm also a Penguins fan. And thank you for having me.
Awesome. Thank you, Manpreet. Thank you for giving such an excellent summary and highlighting all of the wonderful faculty, including yourself, who are leading the charge for POCUS across the department on your birthday, no less. So happy birthday. It is 1:03, and I know some may be dropping off, but we have been getting a lot of the same questions. So any who are interested in your answer, I encourage you to stay. And the question is first from Dr. Sobransky, but also from others. We have great evidence that POCUS improves safety for procedures and great evidence that POCUS ultrasound improves diagnosis in some cases, but there has not yet been great evidence that point of care ultrasound for diagnosis improves patient outcomes. A couple of ED studies show that it doesn't. So is that a barrier for widespread implementation of POCUS? And how do you feel like we should proceed in that arena?
Yeah, I'm not sure. I feel like we either proceed or we kind of get left behind at this point, right? I think when we have enough of a structure and enough devices, there is no option. I'm also actually looking at some of these questions in the chat and getting the same kind of vibes of, I'm an OG attending, how do I get on board? How do I think about safety? I think Mikhail and I talk about this a lot as well, right? There's been no lawsuits in terms of not in terms of excessive use of POCUS. There has been a lawsuit for not using point of care ultrasound when it is applicable. So again, I kind of go back to my point. It's here, it's in everyone's hands. Do we want to be part of that movement where all of us are trained and ready for our learners, or do we want to be left behind? Doing it safely and in a structured way is going to be key. And I hope we can do that.
And I do hope also, I think, hopefully device costs will come down as faculty expertise continues to go up. And hopefully that will also pave the way to remove a few of the other additional barriers to more widespread adoption and familiarity. Yeah. All right. With that, we are at 1:05. Thank you so much for sharing your wisdom and expertise with us. Happy birthday. And thank you all for being here.
Thank you, guys.